What is going on, everybody? Happy Tuesday. Today's actually happy Wednesday. This is going to be episode number 14, and we're going to be touching on 3 different subjects. We're going to be touching on low testosterone levels, how to approach the patient with low testosterone levels. We're also going to be touching on hyperlipidemia, statin use, and then we're going to be answering a question regarding family medicine. So we're going to be this is going to be kind of what I wanted to do from the beginning and answer, 3 different questions very succinctly, very quickly, give you the high yield points that you need to know. Before we get into today's episode, I wanted to ask, if you haven't already done so, I have put up a survey, and this is the reason why I haven't done an episode in a week, because I wanted to get some feedback from you. I wanted to know exactly what it is that you want out of these YouTube videos, what it is that you want out of these podcasts, because obviously I'm doing these in order to better help everybody out there, right? So I created a survey. It's 3 questions, multiple choice. There's a 4th question if you want to answer or not. It's an optional thing just to give any feedback, but it's 3 questions, multiple choice, as to what medium you prefer, how many times a week, and what types of things I should post. Click. Takes 30 seconds. You're done. You can find the survey at physicianassistantboards.com/survey. And I'll put that link here in the notes, in the YouTube and podcast notes. That way you can click it, go to the survey, takes 30 seconds. And this way I know what type of information you're looking for. This way I know how to tailor the YouTube and how to tailor the podcast to better serve your needs. So let's get into today's episode. We're going to be touching on, first we're going to start with low testosterone. And I'm going to read the question first. And this comes from Rachel. And she says, "Hello, Andrew. I would like to suggest a topic for the daily YouTube review. I work in internal medicine, and we will occasionally screen men complaining of fatigue for testosterone levels. I would like to know if we treat based on total or free testosterone, and is it based on age? How do you know which dose to start?" So as opposed to actually getting into the doses, I want to touch on a few important points here, because lots of people will order a testosterone level when they shouldn't be ordering testosterone levels. Lots of clinicians will start treatment that on patients that don't necessarily require treatment. The only reason or the only indication to treat with a testosterone supplementation, whether that's an injection, whether that's gel, is because the patient has hypogonadism, right? We have a low testosterone level, a low total testosterone level, and we'll get into the exception in a bit, but a low testosterone level plus symptoms. This is very important. Plus symptoms, because giving testosterone doesn't come without side effects in its own. So the patient must be deficient in total testosterone, they must have symptoms, and the symptom of fatigue is not very specific, so we can't really use that. The symptoms that we really want to base the findings or the treatment is going to be based on low libido. We're also going to be looking for erectile dysfunction. We're going to look for osteoporosis. We're going to look for gynecomastia. These are all a lot more specific, and this is what we should really guide therapy. We can also look for a small testes, right? So small testes, gynecomastia, osteoporosis, low libido, hair loss. These are all more specific, as opposed to looking for things like depression or fatigue. If the patient simply has fatigue, don't even screen with a testosterone level, because you're not going to treat. Now, when you are drawing up the labs, get a total testosterone. You're going to get a total testosterone, and you want to do this on 3 separate occasions, right? You want to do this early morning, and you want to do this fasting. So we're going to draw the total testosterone level, and if that comes back low, then we're going to do it 2 more times, and then we also want to add FSH and LH, and this is going to help differentiate between primary or secondary hypogonadism. If the LH and FSH is severely elevated, or elevated, I should just say, then we're talking about primary hypogonadism. If FSH and LH are not elevated, then we have secondary hypogonadism. And this is then going to lead you down a path as to different types of testing, like prolactin levels, MRIs, things of that nature. So that's how we approach the patient with a low testosterone. Total testosterone. Now, the one exception here is if the patient is obese. If the patient is obese, then we might have a falsely low total testosterone level because of the seroprotein, the sex binding protein hormones. So if we have a severely obese patient, then at this point, we probably want to get a free testosterone level. And typically the patients with a normal testosterone level typically patients that are obese that don't have hypogonadism will have a low total T4, a low total testosterone level. However, they will have free testosterone levels that are normal. So if you have severely obese patient, get the free testosterone instead of the total. Everybody else, total is just fine. Typically, a number under 300 is considered to be deficient in testosterone. So that's question number 1. Now, let's move on to the second question, and this is going to be from Michael. Now, Michael says, I'm in PA school down in Albuquerque. Love the daily videos you've been putting up this week, and in general, super helpful to hear real-world stories from a practicing PA that is also young, like most of my class and I. I was wondering if you had any advice for my first rotation that starts early in April. It's family medicine, and it's pretty intimidating starting out rotation so broad. I'll be with a seasoned family med physician of 36 years in practice. Any advice in general would be very much appreciated. So I'm going to give you 4 things that I think are important, not necessarily for those even doing a family medicine rotation, but for anybody in practice, specifically here, family medicine. Now, tip number one, know the bread and butter of medicine. Know common things. Common things are common. Don't spend hours studying the zebras, the things that don't necessarily matter. Know the bread and butter, no diabetes, no hypertension, hyperlipidemia, etc., right? That's what you need to focus on in family medicine. You're going to get a lot of URIs, you're going to get a lot of gastroenteritis, you're going to get a lot of things that aren't as interesting, to be quite honest with you. A lot of things that don't necessarily require treatment. A lot of these things are self-limiting, and that's what you're going to learn. The next thing that I want to talk on is something that I kind of struggled with early on, was the notion that unlike the ER, you don't know what's wrong with the patient immediately. Meaning, if you suspect hypothyroid and you want to draw a TSH, you're not going to get that TSH level for another week. So you have to be patient, right? You don't always necessarily need to treat the patient that's coming into the family medicine clinic immediately, because you're not going to have labs to support your diagnosis until a week down the road. With that said, I want to move to point number 3. Point number 3 is not to shotgun labs. Another way of saying this is first come up with the diagnosis and then come up with the treatment. Lots of students tend to jump to treatment before the diagnosis. If you don't know if you don't have the diagnosis, you don't know what you're treating. Meaning, the patient comes in with abdominal pain. Now in the ER, obviously, you don't want to diagnose first if it's life-threatening. You want to stabilize the patient first, treat, and then you can figure out what's wrong, right? But in family medicine, it's the opposite. Why does the patient have abdominal pain? And then we can move on to diagnostic testing and treatment. Do not shotgun labs. Be very specific and methodical with your lab testing. The patient comes in with fatigue, for example. You suspect thyroid, get a TSH, get a CBC, and move on, right? Don't necessarily, like we said earlier, get a testosterone level because of fatigue. Don't just shotgun these tests. Be methodical. That's what's going to separate you. Another tip that I picked up while doing rotations was to actually read the notes from the attendings in the specialty. So for example, you're going to do a lot of referrals. When you send a patient to cardiology, for example, they'll typically email you or mail, or however your clinic is set up. They'll give you the report that the cardiology wrote up. Read the report, read their findings, read their diagnosis, read their treatment plans and their justifications. I learned a lot from looking at these notes. So that's number 3. And lastly, I want to talk about simply listening to your patients. Learn to listen. That is something that students struggle with the most, because they go into the room with an agenda. They go into the room, having their they see the complaint, the chief complaint, and they typically write down their ROS questions, their HPI questions, up front, and they go in there and they want to just do a laundry list. Go in there, sit down, listen to your patients. The better you get at this, the faster your visits will be, and the more the patient will feel like you care, and the better care you'll be able to give. Because if you're asking a question with another question in mind, you're not really listening to the patient. And if you're not listening, the visit will take that much longer. So those are my tips for starting out in family medicine. Now, moving on to number 3, we're going to talk about statins. And this one here comes from Brooke. And she asks, do you know if they still test over specific LDL goals from ATP3 for hyperlipidemia? Or have they advanced the question to address the 2013 update for cholesterol treatment? She's talking about the boards here. And here's my opinion on hyperlipidemia management. Don't focus so much on LDL goals, right? It used to be that we treat the high-risk diabetics to an LDL less than 70, to the diabetics to a goal under 100, right? But here's the problem with treating to goals. The only lipid-lowering medication that has proven to reduce mortality are statins. I'm talking about lipid-lowering medication, right? So I'm talking about things like niacin, talking about things like gemfibrozil. The only thing that has proven to reduce mortality with this class of medication is going to be the statins. These medications have proven to reduce mortality. So what does this mean? This means that if you're already on a statin, then what's the point of adding a second or third medication just to make the numbers pretty, right? It's not necessarily going to do anything. Instead, focus on, do they need low intensity? Do they need moderate intensity? Do they need high intensity statin therapy? Now, certain guidelines do recommend to check an LDL after starting, maybe a month, 2 or 3 months after starting, but that's only to test for adherence, because you're not testing to increase the dosage. They're already on the medication that's going to lower mortality. What is the point of adding more? What is the point of increasing the dose and or adding more medication? There is no point. So there's really no point in doing serial LDL testing, serial HDL testing. The point is, if the patient has hyperlipidemia, if they have a high risk, start them on a statin. Depending on the percentage of their risk, you're going to do a low, moderate, or high intensity statin. You're not treating to an LDL goal. You're not treating the pretty numbers. You're treating the actual patient. You want to extend or prolong their lives. And that's the whole point of it all, isn't it? So these were 3 questions. We touched on a low testosterone, how to approach the patient with low testosterone. We touched on my 4 tips to starting family medicine. And then we touched on statins, hyperlipidemia. So if you guys have any questions, I'd be more than happy to help, more than happy to answer. You can do this one of a few ways. You can either DM me on my personal Instagram, AND_REID, or you can DM me on the PA Board's Instagram, which is PABOARDS. Or finally, you can send an email to andrew@physicianassistantboards.com. And again, if you haven't already, I'd really appreciate your feedback. I'd really appreciate this. The survey is anonymous. Click the link in the show notes here on the YouTube or podcast. That's physicianassistantboards.com/survey. What I mean by anonymous is that I'm not going to be able to see who actually sent the review. So if you're worried about maybe me knowing who sent, I'm not going to know. It's completely anonymous, but I do appreciate your feedback. For those of you that have already done this, thank you so much. For those that haven't and plan to, thank you so much as well. Again, the point of all this is to really help you as much as possible. Thank you guys so much. I'll check you guys on the next episode. Take care. Bye.